Hello, my name is Anna Six-Samuels. I'm an assistant professor of pediatrics in the Division of Pediatric Infectious Diseases and one of the associate hospital epidemiologists for the Johns Hopkins Hospital. It's my pleasure today to speak to you about some special populations in pediatrics, including infants, impact on breastfeeding, and MIS-C. So today we're going to discuss the implications of maternal COVID-19 on newborns. We'll review the differences in clinical manifestations of SARS-CoV-2 in infants and understand the clinical manifestations of MIS-C. I've begun giving a caveat that the literature and knowledge about SARS-CoV-2 is obviously evolving quickly and new information may be published. I have made an attempt to focus on newer articles that were more recently published where feasible. So let's discuss the impact of maternal COVID-19 on newborns. In particular, COVID-19 in moms has raised two big questions. One, most women who are delivering in the hospital setting, can they be with their infants or should they be separated? And then what's the impact on breastfeeding? So in one systematic review of over 600 neonates, there was actually no difference in acquiring SARS-CoV-2 among the babies who were breastfed versus formula fed, or those who were isolated away from the moms versus nursing with the moms. And in fact, the ones that were isolated away from the moms, ironically, had a higher percentage of SARS-CoV-2 incidence. And in another prospective multi-center cohort study from Italy, there was about 60 pairs of mommies and babies. In this case, the babies all roomed in with their mothers, and the majority of them did breastfeed. The babies were tested on days 0, 7, and 20, and only one infant was diagnosed with SARS-CoV-2 on day 7, and that infant had a mild and self-resolving illness. So these studies are suggesting that infants are doing well when they are with their mom. How about the outcomes of the babies born to the moms with COVID-19? So in this retrospective cohort study of about 100 neonates in New York, the newborns roomed in with their mom routinely. The mothers were required to wear masks and do hand hygiene, and breastfeeding was encouraged. What they found was the moms with more severe maternal COVID illness did have an association of delivering about a week earlier. None of the infants in this group had evidence of vertical transmission, despite even including severe cases of maternal infection. And 2 infants did test positive at day of life 3 and day of life 6 who had been exposed to their mom with COVID. And in both cases, the babies were asymptomatic. So again, suggesting that babies born to these moms are not getting sick with SARS-CoV-2 or significant COVID infection. Well, what about congenital COVID-19? And, I think that the literature and the questions around this have been kind of oscillating over the last few months. Initially, there was concern that potentially babies were really born with COVID and born with this virus. However, then there was all of these cohort studies suggesting infants are not born with COVID. Now we're starting to see a collection of case reports that perhaps there is a rare but feasible possibility that some babies are born with a congenital infection that might even have manifestations. So in a US registry cohort, about 1 to 3% of the infants were positive within 96 hours of birth, suggesting either extremely early perinatal acquisition or truly they were born and had a positive test. And there's a growing number of these case reports with a potentially clinical syndrome. In this one particular report, there was a 34-week infant, and they were tested positive by PCR at 24 hours, at 48 hours, and the placenta was also positive. The baby developed a illness with fever, respiratory distress, and hyperbilirubinemia. Ultimately, the infant did recover and was discharged home after 21 days. And then there's a recent Nature investigation that kind of has a proof of concept to it. They did a fairly elaborate investigation into cytokines and testing the blood from the umbilical cord and the mom for various items. But the high level take home is that there was 2 babies that were both positive for SARS-CoV-2 at birth by NP swab. One of them quickly became negative really within the day, but the cord blood had positive IgM antibodies, suggesting the infant really had some immune response to virus. And both of these babies, the SARS-CoV-2 virus the actual viral material was detected in the umbilical blood. Both of these babies were asymptomatic. So in this paper, they support that the congenital infection was likely there, but they actually had no congenital disease or manifestation of that infection. So what are the implications of isolation precautions for these babies born to moms with COVID? Both the AEP and WHO do support breastfeeding, even if babies are born to moms with COVID. And really, the separation of infants from their mother is no longer supported. Mothers, however, should make an attempt to reduce the likelihood of transmitting the virus to their baby, and so really should be wearing masks when in close contact and breastfeeding, and perform hand hygiene. And other household members who might also be infected should also be doing these same precautions. The AEP continues to recommend testing of infants born to moms with COVID within 24 to 48 hours of life for detection of possible congenital infection, which could potentially, as we're still learning what that means, inform future care and just inform general epidemiology. It's reasonable to consider newborns born to COVID born to mothers with COVID as exposed, since they are around their mothers. And it's also reasonable to consider the possibility of congenital infection. Locally, the way we've approached this is keeping babies on droplet precautions for 14 days of age, both either in the hospital or for outpatient visits to kind of cover both of these scenarios, and also potentially protect the baby from outside exposure if they have a parent visiting them in the hospital. So let's transition to clinical manifestations of SARS-CoV-2 in children and some focus on infants. In this Lancet systematic review, what we're learning is that many children may in fact have asymptomatic infection or such mild symptoms it really doesn't get on anyone's radar. Of those who are symptomatic, fever, cough, sore throat, and rhinorrhea are the top most likely symptoms, followed by less specific symptoms like myalgia, nausea, vomiting, GI symptoms, and rash is very rare. Most children have a clear family exposure to someone else in their household, or they're living in a high risk, an area with high transmission. Interestingly, in this systematic review, 6% of the children diagnosed with SARS-CoV-2 also had another concurrent bacterial or viral infection. And so I think this is an important take home that I'll say again later, that a diagnosis of SARS-CoV-2, particularly by PCR, does not exclude something else could be happening. SARS-CoV-2 can shed for a long time in some patients for reasons that we're still learning about. And so even if that test is positive, it's still important to consider potential other etiologies of their symptoms as it's appropriate. Fortunately, children have more mild illness than adults. This is now an older study, but from the MMWR, but they compared the prevalence of symptoms between pediatric and adult patients. And really, adults just were more symptomatic across the board. Children, especially young children, for reasons we're still understanding, may be less susceptible to infection, and they are just also more likely to have asymptomatic and unrecognized infections. And also, fortunately for pediatrics, hospitalization rates among children are much lower than adults. In this evaluation, their rate was 8 children per 100,000 as compared to 164 adults per 100,000. However, of children admitted, 1 in 3 were admitted to the ICU. And perhaps this is related to MISC, but this rate is comparable to the adult intensive care rate. Children less than 60 days of age are more likely to be hospitalized, likely because we're evaluating them for bacterial infections as well, and due to their young age, they generally have mild illness and can be discharged after 2 days. So how might the presentation of COVID-19 be different in infants as compared to older children and adults? The majority of infants have recognized household contacts with either a prior diagnosis or symptomatic adults in the home. So they have to get it from someone, and it's usually the folks in their home. The same symptoms are the most common symptoms in infants: fever, nasal congestion, cough. Perhaps unique to infants, Infants may be more likely to present with fever alone as the only recognized symptom. They also may just not feel well, and they manifest that as poor feeding. And there are now several case reports describing infants presenting with seizure-like activity, even sometimes in the absence of EEG findings that corroborate seizure-like activity. So I think those are some of the more unique features of infants. Many infants may, in fact, have neutropenia and lymphopenia on their CBCs, and this matches with at least my clinical experience as well, as kind of a viral-mediated marrowsuppression that then resolves. It's important, again, to consider concurrent infections. There's plenty of reports of infants presenting with both SARS-CoV-2 and bacteremia or UTIs. And so it does sometimes beg the question, is it an incidental SARS-CoV-2 diagnosis that they already had this, they're still just shedding, and now they have a bacterial infection that's prompting the symptoms that bring them to care? Or is it truly concurrent infection? Both might be possible. Thus far, I've not seen a report of concurrent bacterial meningitis and COVID-19, but it might just be that this is a relatively rare outcome. And there's a splattering of reports ranging from 0 to 17% of infants with SARS-CoV-2 that have a concurrent other virus. And it is plausible that if exposed to SARS-CoV-2, they're very well exposed to another type of virus. I'll say that we're seeing plenty of rhinovirus in our community, and so that might be one of those other concurrent viruses. Most infants less than 2 months are hospitalized. Overall, they have good outcomes. There's rare reports of severe infection, and the cohort studies really support self-resolving infections without deaths. And this is in clear juxtaposition to some other viruses, for example, influenza virus, that really had a J-shaped distribution of illness severity, where the youngest ages and highest ages were most severely impacted. The SARS-CoV-2 virus really does not seem to be having that severe impact on young infants like we initially feared. And so we are fortunate and lucky and thankful for that in pediatrics. Now let's transition to multisystem inflammatory condition in children. So the multisystem inflammatory condition, or MISC, is a post-infectious secondary illness caused by an immune response about 2 to 4 weeks after the initial infection with the SARS-CoV-2 virus. Most patients are previously healthy kids, school age. The median age is repeatedly around 8 to 9 years, but the reports have ranged from infancy through now adulthood. The presenting symptoms are fever and abdominal symptoms. Kids present with belly pain, vomiting, diarrhea. Sometimes the belly pain is so severe they think they have a ruptured appendicitis or acute abdomen. And then they also might have rashes like conjunctivitis or other types of rashes. It's a progressive illness, and the majority of patients, 70 to 80%, end up going to the ICU. Many with more than 4 organs involved and more than 4 biomarkers of inflammation. Death is also much higher in this group of patients, about 2%, as compared to the death rate of acute SARS-CoV-2 infection or COVID-19, which is well below 1% among children. In this graph, this is from a New England Journal paper, and it nicely shows the temporal relationship where the peak of SARS-CoV-2 infections in that community were around the beginning of April, and then the peak of MISC diagnosis was exactly 1 month later. And we're seeing this again in kind of a new second wave surge that we're experiencing, unfortunately. I'd like to briefly actually read through the CDC's case definition, and I'll point out the slight differences with the PIMS definition. So in the CDC definition, MISC is age less than 21 years, presenting with fever for at least 24 hours, evidence of inflammation on labs, with a clinically severe illness requiring hospitalization with more than 2 organ involvement, no alternative diagnosis, and a positive SARS-CoV-2 by any test, really, antigen, PCR, serology, or known COVID-19 exposure or plausible exposure. I put little asterisks with differences from the PIMS definition. The PIMS definition says at least 1 organ dysfunction rather than involvement, so it's a little more specific about actual dysfunction. And then the requirement for positive COVID-19 testing is not there. In this graph, the authors showed the spectrum of symptoms kind of juxtaposing MASC to acute COVID-19. And there's very clear differences. So MASC, it's inflammatory. All the patients are febrile, and they all generally have some kind of abdominal symptom, diarrhea, vomiting, and many have rash. Whereas in COVID-19, they might have fever in a fair proportion, but they really don't typically have GI symptoms. They really don't typically have a rash, and they have more respiratory tract symptoms, cough, rhinorrhea. In MISC, the majority of patients will progress to have some cardiovascular symptom, including hypotension or other things that I'll mention in a moment. And a fair proportion may present with neurologic symptoms like headache or even meningismus. So again, important to keep both MISC, but other potential etiologies on your diagnostic differential, including bacterial meningitis, toxic shock, things like that, that can have overlapping symptomatology. So in this graph, I actually combined data from two articles. The point here is that there's a high prevalence of cardiac abnormality in these children. And so the majority have an elevated pro-BNP indicating some heart strain. And the majority also have elevated troponin indicating a component of myocarditis. Many have a frankly abnormal echo with depressed ejection fraction, abnormal EKGs, evidence of pericardial effusion or pericarditis, or obvious aneurysms, coronary artery dilatation, and mitral valve regurgitation is less common. So it's a child that presents with fever and abdominal symptoms, maybe a rash, and then progresses to have frank cardiovascular compromise. Interestingly, some authors have now tried to study what we're seeing in real life, but there might be some phenotypic variation across the age spectrum. In this paper, they just grouped symptoms by age group. And what they found was that the young children were a little more likely to have dermatologic or mucocutaneous findings, and they were also more likely to meet the definition for Kawasaki's disease, and I think likely because of those mucocutaneous findings. Whereas the older children were less likely to meet the Kawasaki's disease definition and more likely to have the myocarditis and frank GI symptoms. The CDC also did a machine learning assessment of a cohort of 570 MISC cases across the US, and they found basically three groupings. In one class, it's what we think might be the most classic kind of MISC description. Very ill children, more than 5 organs involved. They nearly all had cardiac and GI involvement, and they nearly all had positive SARS-CoV-2 antibodies. And this seemed distinct from KD and distinct from acute SARS-CoV infection. The second group had mostly respiratory symptoms, and they mostly had positive PCRs. And the authors postulated, could it be an overlap with acute viral infection kind of morphing into MISC, or was this really just acute infection? And then the third group might be a little younger, more mild, more likely to have those mucocutaneous changes, and had a fair proportion of antibodies, but also some PCR and antibody. And they were more likely to meet the Kawasaki's disease criteria. Again, another theme that the younger children might be more likely to meet the Kawasaki's disease criteria. So brief comment on treatment. Really, most children with acute SARS-CoV-2 don't need any particular treatment, just supportive, and they'll resolve. They can consider remdesivir once they have respiratory decompromise. We're still learning about the effectiveness and the risks of that medication. Some more tailored therapies like tocilizumab could be considered in more progressive or severe illnesses, and thrombosis prophylaxis as well as considered. In terms of treatment for MISC, IVIG has become the mainstay of treatment, with the addition of steroids if there's cardiovascular decompromised shock or Kawasaki's disease-like findings, and aspirin for any coronary or Kawasaki's disease-like considerations. And rarely in refractory cases, those more tailored immunomodulator therapies might be considered. So in summary, the take-home points for today's talk are that breastfeeding is supported for moms with COVID-19. However, they should wear a mask and perform hand hygiene when in close contact with their infant. Congenital SARS-CoV-2 is possible, but uncommon. Infants may have different symptoms of acute COVID-19, and it's still important to consider bacterial infections and alternative diagnoses, even with the diagnosis of SARS-CoV-2. MIS-C is most commonly presented with fever, abdominal pain, vomiting, or diarrhea. So that's the picture you want to imagine, the kid with belly complaints and fever who is getting more sick. And it can be rare, but a life-threatening complication, and children can rapidly deteriorate once they start to develop cardiac dysfunction. So prompt assessment and treatment is important. With that, I'll say thank you, and I look forward to your questions.